Recording in progress.
Bismillah ar-Rahman ar-Rahim. My name is Dr. Kamran, Shaikh. So we will discuss today about the benzodiazepines in the first part of our session. So benzodiazepines, as you know, that they are used for different purposes, and one of the purposes is epilepsy. Then anxiety is the most common use for benzodiazepines, and so they are also used for muscle spasms, pre-medication for anesthesia. For example, the midazolam or dormicum, that is used as pre-medication, or sometimes diazepam may also be used for that purpose. Uh, and lately, their use is being like it's becoming more and more uncommon, benzodiazepine use, but it is still there. So we can't say that it is not there. You know, they are still in use, and they have a place in psychiatry. Uh, Although I mean, their use is not as common as before, but sometimes there is no other choice. So mostly prescribing guidelines, and most of the guidelines are very much against the benzodiazepines for being more than maximum 4 weeks. So as little as possible, and they are very right. Uh, British Association of Psychopharmacology also hold a very similar view. So we are like united in that it should not be prescribed for more than 4 weeks. However, BAP say that sometimes long-term benzodiazepine use is justified, and in those situations we shouldn't be reluctant to use. For example, in very chronic intractable OCD, and that could be one example. Again, we will come to the antipsychotic augmentation. There is no evidence, but sometimes you have to use them in order to control the agitation, and even for the as a long term use. So sometimes, in tardive dyskinesia, etc. So there are indications for long term use as well. We should bear that in mind, but overall we should discourage their prescription. And especially, my personal view is, and that's what the BAP also say, that see if the patient is kind of prone to addiction or not, and if the person is like if they have an addictive personality, for example, personality disorder, substance misusers. So we should definitely discourage their use for that purpose. And in someone very genuine, an elderly patient, for example, of course we have to see the cognitive side effects and other things, or any other person whose anxiety is unbearable and there is no other solution. So as a last resort, in those patients, their long term use may be justified. However, overall, and by the first option, we should discourage their long term use. So uh, the benzodiazepines can be divided into long acting and short acting, and their use was more in the past and less lately. So they have an anxiolytic effect. They can be used for agitation, to counter the agitation, and then generalized anxiety disorder, but their use should not be more than a month. So they are clearly very addictive. There is no doubt about that. Even if the patient we are using for long term, they are addictive and they will get addiction to that. So we have to measure the pros and cons, risks and benefits, and then decide an exceptional use for an exceptional patient for the long term, not everybody. So generally try to avoid them, because once we give it, that's my personal view, but once we give it in only for 4 weeks, it may become very difficult for even for us to stop them. So generally avoid them if you can. Avoid them at all. Use promethazine or anything else which is not that much addictive, but not benzodiazepine if you can. And long term use may do harm. So they can be used in social phobia, panic disorder as well, and their short term use is justified. PTSD and phobias. So social phobia is basically the social anxiety disorders, but when we come to agoraphobia and specific phobias, and then the PTSD, their use is not good at all, because in PTSD people are very likely to get the addiction, and they can get dependent to benzodiazepines very easily. So it can be quite harmful, and it may even be ineffective. So in other cases, for example, in generalized anxiety disorder, it was effective. In agitation, it was effective. Social phobia, panic disorder, short term use was effective. But for PTSD, don't use it, because their condition is very chronic, and often the people with PTSD, they get addicted to alcohol and other things. So it's better to avoid them at all in patients with PTSD and phobias. Personality disorder, avoid at all if you can. Substance misuse people, avoid, because they are looking for it, and they are buying those things from the streets. So you are giving them something which they want to get addicted to. Now there is hypnotic effect as well of benzodiazepines. So the benzos inhibit the REM sleep. So, and then the REM rebound is seen upon discontinuation. So inhibition of REM sleep, basically REM sleep is more of a dreamful sleep, and benzodiazepines, when they inhibit the REM sleep, the sleep will be more kind of peaceful and without dreams. So the nightmares will not be there. So if someone complains of nightmares, especially on promethazine and mirtazapine, quetiapine, olanzapine, etc., and their nightmares are extremely disturbing. In those cases, maybe as a last option, benzos may be considered, but again, try to avoid if you can. Tell them that this is a side effect and this happens with these drugs. If they can cope with the nightmares, well enough. But otherwise, with the benzodiazepines, they inhibit the REM sleep, and so that is an advantage as well as disadvantage at the same time. And then REM rebound is seen upon a discontinuation. So and then so what happens is, if once you discontinue, their sleep will become full of vivid dreams and nightmares. when you are discontinuing the benzodiazepines. So that's what one of the withdrawal effects is, that the REM sleep will come and come at an intense level. There are good hypnotics in short term. There are randomized controlled trials on Z hypnotics, which can be given for up to 6 months. Again, Z hypnotics are as addictive as benzos. So the best thing is to use something like promethazine or Phanergan in those cases. If that doesn't work, then maybe come to the Z drugs. If they don't work, then consider benzos. But the most important thing is sleep hygiene, and mostly if the people can cope and sleep without the use of benzos, then and even if they have somewhat sleepless nights, let them cope with it, because you're giving something which you're like making them addictive of. So sleep hygiene principles mean that like waking up early in the morning, not sleeping during the day except for maybe half an hour during the afternoon, which is a cultural thing. So apart from that, no other dozing off, waking up early and going to bed like not very early, but just at the right time of sleep, usual sleep time, not using too many cigarettes in the evening, avoiding tea and coffee in the evening, and going for exercise, going for walks, and avoiding using mobile phone at the bedtime, rather reading some books so that they like person can get to sleep easily after reading books. But the mobile phone will alert the and stimulate the brain, so avoid watching TV at the time of sleep. These are all the sleep hygiene principles we should ask people. And so then if they don't work, then maybe promethazine. If they don't work, then Z hypnotics. And if they are like unhelpful, then maybe going to the benzodiazepines. Even with the Z hypnotics, if it is zopiclone, start with 7.5, like 3.75, not 7.5. Similarly, if you are giving Stilnoct or Zolpidem, give 5 milligrams in the beginning, not 10 milligrams straight away. And in the UK, like we had this practice of giving 3.75 milligrams, and it worked. So use less doses of Z hypnotics, even and then so that is about the sleep hygiene and the use of hypnotics. Yeah, there are some conditions in which you must give hypnotics. One is bipolar, and if there is a risk of mania. So, and there, especially with the rapid cyclers and the person whom you know that they relapse once or twice a year inevitably. So for them, like give them hypnotics, whatever is appropriate. Sometimes you might have to use the benzodiazepine hypnotics, but keep them their sleep very good. That is the main exception. Other exceptions may be some of the depressed individuals who get more depressed by sleepless nights, and if they feel that they sleep well, their depression will improve, you can try in them. But the must use is only one, that is for mania. So don't take the risk and give them good enough sleep so that they don't relapse into manic episode. Then, so benzodiazepine hypnotics are flurazepam, flunitrazepam, temazepam, triazolam, and lormetazepam. They are all the hypnotics. Now, in Pakistan, alprazolam, bromazepam, diazepam, lorazepam, etc., they are also used as hypnotics. But when we come to the West, then these long acting benzos are not hypnotics, and even if we give them, the patient says that it reduces my anxiety, doesn't give sleep to me. But in Pakistan there is a belief system as well, and maybe something to do with the pharmacodynamics there in that population, that those long term benzos also work as hypnotics. So many people take this these Valium and other things, and medium acting benzodiazepines. Uh, Chat, clonazepam is the one of the most commonly used for acute mania with antipsychotic. Yes, very right. And again, Dr. Hayat, it's a cultural thing. So yeah, clonazepam. I personally go for clonazepam, but when I was doing my SR rotation in London, so we had to cover two different hospitals. One was it more kind of east, and one was a little bit west. So the hospital in the east, they were using clonazepam for mania, and the hospital in the west, they were using diazepam for the same thing. So yeah, diazepam and clonazepam, they are all equivalents, but yeah, clonazepam has relatively less street value than diazepam, and that's why it is preferred. And I also generally use clonazepam in my patients. Generally, promethazine is preferred, then Z-hypnotics, and then benzohypnotics. So that will be my choice usually. Depression. So there's no advantage of benzodiazepines. Now I'm not talking about hypnotics, but generally benzodiazepine. So you can give for initial 2 weeks to prevent side effects, especially insomnia and SSRI induced agitation. Personally, I would avoid this uh, unless it is necessary. So I won't give every patient fluoxetine and diazepam for 2 weeks. No, I would just give fluoxetine. I would just give sertraline and nothing else. Yes, if the patient is very reluctant to take, if they have a history that they can get agitation on uh, these benzodiazepines, then maybe in those cases, in those selective cases who are very, very prone to side effects, and you know that they get side effects on each and every medication and they complain of side effects, maybe in those selected patients you can give benzodiazepines along with these psychotropics. Otherwise, avoid them if at all possible. Okay. Then the next one is so psychosis is one. Now in the psychosis is another indication, and for rapid tranquilization, and psychosis and generally mania as well, let's say. So they are used for rapid tranquilization in psychosis as well as in mania. So they are used as a monotherapy or in combination with antipsychotics, as Dr. Asad just mentioned. Catatonia. Now, this is one thing when I was reading the Maudsley prescribing guidelines, which I used to prepare my lecture. catatonia was not mentioned here, but then I just contemplated, pondered that yes, we do use in catatonia, and there's only one benzo which we do use, and that is lorazepam. So that is another indication where you must give benzos. So one was to for hypnotics. I said that that for as a hypnotic anything, promethazine or zopiclone, but you must use hypnotics in the patients who are at risk of getting mania, manic episodes. Similarly, in patients with catatonia, you will have to use catatonia like the lorazepam, so benzodiazepine, and the drug of choice is lorazepam in this case. And yes, and it can be given IM in this case. You're very right, and there is a benzodiazepine like the lorazepam challenge test as well. So you give it as IM and see whether it works or not, and if it works, then it is catatonia. So that is kind of confirmation in order to confirm the diagnosis of catatonia. And we can go for higher. Yes, lorazepam has to be like, generally we can't go above 4 milligrams per day in general, but in other cases, but in catatonia you will have to go for very high doses, which may be 10 milligrams per day, 8 milligrams per day. So there is no evidence of benzodiazepine augmentation of antipsychotics. However, personally I have seen that they can take the edge off. So if you feel in your chronic psychotic patients who have become treatment resistant and you can't even give clozapine, you are already giving them 2 antipsychotics at very high doses and they are not working, then maybe to reduce the distress associated with hallucinations and delusions, you can use some clonazepam in those selected patients. Otherwise, there's no evidence that they will augment. So they will not augment antipsychotics because the hallucinations and delusions will not go by use of benzodiazepines. However, if they are really, really distressed, then you might have to give them some. Tardive dyskinesia, little evidence. But I think in akathisia there might be some evidence, although the first line is propranolol in akathisia, but benzodiazepines also have some place. Tardive dyskinesia, generally tetrabenazine is used. Now, headaches. So now the side effects of benzodiazepines. So they can cause headaches, although they can relieve the tension headaches, but it is also reported as one of the side effects. Confusion, ataxia, dysarthria, blurred vision, GI disturbances, jaundice, paradoxical agitation and excitement, impaired cognition, memory problems, attention and processing speed goes down, and these cognitive effects can even persist even after discontinuation of benzodiazepines. And there's a 50% increase in the risk of hip fractures in the elderly, and that is secondary to the risk of falls, especially with the short-acting benzodiazepines. And anterograde amnesia is another thing which can happen, and then effect on driving. So they will kind of prolong the reaction time. So that's why they are not very safe for driving. And disinhibition, along with the paradoxical agitation, sometimes disinhibition can also be seen. Aggressive behaviors which can be attributed to dose of the benzodiazepines and other personality factors and other comorbid substance misuse. So benzodiazepines alone should very rarely cause agitation or aggression, but they can on their own as well. But generally, in the general adult population, if people are getting aggressive on benzodiazepines, consider other things as well, other substance, illicit substance misuse, or personality factors. In elderly population, the benzodiazepine paradoxical agitation is very common. So use benzos with great care in elderly and try to avoid if you can. There is some association with dementia, but evidence is weak. Now, respiratory depression can also happen, but it is very rare. So, like 50 years ago, barbiturates, phenobarbital, they were used a lot for sedation. And those barbiturates were kind of linked with respiratory depression, and deaths were happening very commonly. This is not a very common problem with benzodiazepines. So, fatal respiratory depression is very rare, but it can happen, especially with the parenteral route, IV mostly, or even IM, and then the buccal route, and then the intranasal administration. Now, IV diazepam is also painful, so we generally don't give. If you are giving, have somebody from medicine or anesthesia with you. Otherwise, don't use IV diazepam. And you have to have emergency trolley in which flumazenil should be ready if you are using IV diazepam for an extremely agitated patient. I've never used it in my patients, and I've seen only once when one of the very senior consultants used this into psychiatric intensive care locked unit, in which the patient was extremely aggressive, and then that senior consultant gave slow IV injection of diazepam. At least I think it was given over 2 minutes, and for 2 minutes that patient was being restrained by the nursing staff. Again, that is related to linked with the thrombophlebitis. So there is a risk of thrombophlebitis even with that slow injection. And it's so what like its water solubility is also in doubt. I don't know what can we dilute it with water or not. So what happens in the UK is that there is an oil-based emulsion which combines water and oil and diazepam together, and it is called diazimals. So that is used in the UK for that sedation purposes when IV diazepam has to be used. Drug interactions. So first of all, we go with the pharmacokinetic drug interactions. So the benzodiazepines are not enzyme inducers themselves. However, they are metabolized by CYP3A4. So when you give erythromycin or clarithromycin, Clasid or Claricid, that will increase benzodiazepine levels as it is an inducer of CYP3A4. Same with some SSRIs, and then some SSRIs can increase the benzodiazepine levels. So if you are giving it with SSRIs, just check the drug interactions onto Medscape drug interaction checker or drugs.com drug interaction checker. And then ketoconazole, which can also inhibit the cytochrome P3A4 and can increase the levels of benzodiazepines in that way. Pharmacodynamic interactions are also reported. So that is generally increased sedation, because one thing is olanzapine, and if you go with the generic formula of olanzapine, it is something like dibenzodiazepine uh, or or thianobenzodiazepines. So this is so that's why, they are very structurally very much related to the benzodiazepines. And so yeah, it is oil based. Yeah, okay. And in previous part 2 attempt, an examiner asked about diazimals. It is oil based, yeah. It is mainly oil based because they make an emulsion. So there must be some water as well. Uh, and if I search the product over, I will, what I will do is I will go to medicines.org.uk and I will send you a leaflet, and that will exactly tell us that what are the constituents of diazimals. So it is medicines.org.uk or medicines.ie. Yeah, oil in water, exactly. You're right, Dr. Hayat. So, let's go back to where we were, word pad, and yeah. So, there is an increased risk of cardiorespiratory depression along with methadone, olanzapine, and clozapine. So, avoid benzodiazepines with these drugs, especially when you are giving IM lorazepam. So, do not give any olanzapine within 1 hour of that, or vice versa. If you are giving IM olanzapine, then do not give any benzodiazepine within 1 hour of that. Orally you can combine because the absorption of both will be slow, but do not use very high doses with oral olanzapine. So use very low doses. So that is about benzodiazepine. Any question before we stop? Okay, so yeah, chat. Okay, diazimals contain diazepam dissolved in the oil phase of an oil in water emulsion. Yes, very right. Thank you. Okay, so no other questions. So we stop here then.